All right, everyone, we'll go ahead and get started on this last chapter or this last section of chapter 35, Pediatric Emergencies. This one's going to be reviewing like trauma type stuff. And then at the end, of course, we'll do the 10 quick review questions and hopefully I get all those right. But anyways, we'll go ahead and get started. So it jumps into drowning, which we talked about in environmental emergencies, but drowning is the second most common cause of unintentional death among children. So the pediatric cardiac arrest I've ran, most commonly for me at least, they've been drownings. And so drownings, I've had a kid die in a koi pond, I've had a kid drown in a pool before, and so that I can just think off the top of my head. And so again, a koi pond is like a very small body of water that has a little goldfish in it, and this kid died in it. 3-year-old. And so just be aware, it doesn't take a lot of water for kids to die. Remember, drowning is silent. And so obviously this is caused by hypoxia. Now, remember the rule with hypothermia, unless they're very clearly dead and stiff, that typically if someone's been submerged in cold water, that we would work them. Remember, cold bodies aren't dead until they're warm and dead is the general saying that we could use to help us on exams. And then, of course, I never recommend you dive into water where you cannot see the bottom because you can certainly break your neck and your head, and your neck will break your fall if you dive into shallow water. And so obviously that can be rather lethal. And so signs and symptoms of a drowning is coughing, choking, airway obstruction, difficulty breathing. What's the medical word for difficulty breathing? Dyspnea. Altered mental status, seizure, activity, unresponsive, fast, slow, or no pulse. That would be cardiac arrest. Pale or cyanotic skin. Remember, cyanotic skin is the bluish purplish tint of skin. What do we call it when it's just bluish and purple around the mouth and the extremities? Acrocyanosis. And abdominal distension. So this is just going to be, manage of the ABCs. A lot of times during cardiac arrest, not always though. If they're not, we would call that a near drowning. And so, ALS crews can be helpful with intubation and stuff like and medication and more advanced skills. And so that may be a consideration if you work in a system where you could call for ALS intervention. Administer 100% oxygen. You'd apply a cervical trauma if cervical collar if a trauma is suspected. Remember, generally, if anyone jumps into a body of water or falls into a body of water, or if they use words like that, then you would suspect cervical trauma. Okay, so do keep that in mind. So you may get a vignette where mom walks out and they find kid in the bottom of the pool. You could still suspect cervical trauma in that case. Okay, so unless they specifically tell you that the kid was swimming around in the pool fine and then they suddenly went to the bottom, right, you wouldn't suspect cervical trauma in that case. But if there was any type of falling or jumping into water, then you could suspect cervical trauma. Okay, and so CPR is the answer if they're in cardiac arrest. Okay, and so now, interestingly, trauma itself is the number one killer of children. So drowning is number two. The number one, and this is because for several reasons. The first one is because children don't have a lot of medical issues. I mean, generally compared to like an adult, especially an older adult, they don't have the medical issues that old people have. So of course they're going to die more likely of trauma. One, two, it's also because children engage in risk-taking behaviors. This is partially due to believing that they're invincible, immaturity, just not knowing better. Peer pressure, it's just everything that we've all done as kids can lead to a higher likelihood and also neglect and abuse too. But these can all lead to death from trauma. And so the quality of care can impact recovery. There's a lot of research, there's a lot of work into trauma care, especially regarding children. And so the muscles and bones, really the whole body of children will continue to grow well into adolescence. Okay, fracture of the femur is astronomically rare. I don't think I've ever seen a fracture of a child's femur that I can think of. Other children and adolescents are prone to long bone fractures. Now, you will see this a lot. I broke my arm on a four-wheeler once when I was a kid. Collarbone injuries, fall on outstretched hands are quite common. Stuff like that. You do see those fractures, wrist fractures, finger fractures, ankle, foot. Those things do happen. Now, one thing to add with kids, remember, if they fracture a bone, say you see like a gross deformity of a joint or what you would think would be a bone, you would suspect a dislocation more likely than a fracture. Remember, young people, their bones are quite a bit softer and more resilient. And so if you see what you would believe to be a hip fracture in like a 16-year-old boy, you might think that's probably a hip dislocation. It's less likely that it's fractured. Remember, young people will dislocate so their bones will fall out of socket before they break out of the socket. Okay. Whoa, mind blown. Children are smaller than adults. Who knew? Locations of injuries may be different. So, one thing to think about, and we'll talk about this, is like, you know, I'll just draw this. Y'all ready for a cool drawing? So, this is a ambulance, actually. Okay, I'm not going to draw a star, but boom, ambulance. And so, if this was adult, they might get hit like this. And so, where is this ambulance that's about to plow them over going to hit them? It's going to hit them in the thorax. So when they get hit, they're going to get folded like this, and head's going to hit up here on the hood, and they may even fly off the back of the ambulance, right? So that's the typical injury pattern you'd see with an adult. Now, if it's a kid, where are they going to get smacked? Right in the head. And so this is the problem with kids is they're lower to the ground. And so like in autopeds and things like that. So this is just like one consideration of kids. Yes, they are smaller than adults. Wow. But the idea is they have different injury patterns. And so this would be an example like an autoped. They're going to get smacked right in the head, neck, and chest. As opposed to an adult, they might get hit in like the pelvis or the chest and not the head as much. So there's just different forces involved and different like injury patterns that you would see. Okay. So there's psychological difference. Kids are often injured because of underdeveloped judgment, right, and lack of experience. And so, again, kids, I'm not we anymore, I'm 29, but kids engage in risk-taking behavior, okay? So vehicle collisions, the exact area struck depends on the child's height and the final position of the bumper at impact. So again, you know, um, a, a Corvette is going to have a different impact because it's sitting lower to the ground than an ambulance or a pickup truck when they collide with a pedestrian. And so these are all things that you'll consider. And it also depends on how tall is the subject that's about to get hit. And so generally some of the most gruesome calls I've ran have been, besides people shooting themselves, is people getting hit by vehicles. Unbelievable amount of energy that will go into these people, and it demolishes them. And sometimes they don't die immediately. I've had that happen. This guy got hit right in front of the station in Weatherford, like literally like 20 seconds in front of the station. Wasn't by an ambulance. Is on daylight savings. And anyways, this guy got hit, and we got there so quickly within like 30 seconds to a minute of it happening. It was like the first call of the day. It was like 7 o'clock in the morning. And he had not died yet. So, of course, you have to work him. We know he's going to die because he's like severely injured and on his way out, but he's still agonally breathing and still has a pulse and blood's everywhere. It was a mess, total mess. But, anyways, I'm just pointing out that uh, autopeds are very, 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 very gnarly. I've never ran a pediatric autoped, thankfully. So, anyway, sports injuries, these happen quite a bit. So remember, with contact sports like football, you can get, flank injuries. It's pretty common. They'll get hit in the kidneys, and then they'll have flank bruising, and they might be urinating blood. What do we call blood in the urine? Hematuria. Also, with sports injuries, you might consider the good old comedo cordis. This is like was it Darren Hamlin? I don't know, the football player that got hit in the chest with the helmet and he went to cardiac arrest. Well, remember, the classic scenario is a kid that gets hit in the chest with a baseball or a softball, and he goes into cardiac arrest. That'll cause the heart to quiver. The treatment is ventricular, I'm sorry, uh, defibrillation with electricity clear, AED, right, and CPR. And so head and neck injuries can occur in contact sports. To recapitulate on that, remember, we don't remove helmets unless they interfere with the airway. Okay, so we would generally leave that on. If we can remove the front mask, we will, but generally we don't take off the helmet unless we have to. So remember, we would immobilize the cervical spine. So now the thing to keep in mind is that children have really big head. In fact, a third of their height is their head. Okay, and so next time you see a kid, look, their heads are massive in relation to the rest of their body. Fun fact, my head is also very large, literally and figuratively. So my head is about a third of my height, not really. But I'm just saying that kids have a really big head. And so this also changes their injury pattern because if they fall, they're more likely to like hit their head because they're top heavy. Like that sucker's heavy. And they also, think of how much muscle it takes to hold up that big O head in their neck. And so they're more likely to injure their head. It's more surface area, it's heavier, it's harder to control, it's harder to balance, there's less muscle control, blah, blah, blah. But also, the infants especially have a soft, thinner skull. Remember, for an infant especially, what do we call this area up here? Not my balding hair, but what do we call the soft spot in the head? Right? The fontanelle. And so when that bulges, we might think shaken baby syndrome or meningitis. Okay? When it's depressed, we might think dehydration. Okay? So the scalp and facial vessels may cause great deals of blood loss if not controlled. And remember, just a little bitty lack to the head could create a lot of bleeding. And so when people's faces get disfigured, it scares us. That's okay. Just be aware that's a thing. And so know that that happens. And so nausea and vomitings are a really common symptom in any head injury, but especially in children. So what does that mean? I used to work at a pediatric hospital, and at least 30 times a day, people would come in and their kid would roll off. I mean, it's true accidents, right? Kid would roll off the bed, fall off the bike, fall on the skateboard, and hit their head. And so generally, we would really kind of weigh the risk versus reward of CTing their head because that's a lot of radiation. And so one of the key things we look at is, do they have nausea and vomiting? And so the thing to know is that nausea and vomiting is a very, very, very ominous sign with a head injury. It typically means increased intracranial pressure. And so when you see nausea and vomiting with a head injury, that's a problem in adults or children. And so that's usually one of the greater screening questions we could use is, okay, your kid hit your head. That's bad, right? We need to go to the hospital. But one of the general rules we would use is like, have they had vomiting? If they've had a vomiting, that's a one-way ticket to the CT machine, right? And so that's something that we looked for. So remember, vomiting in any head injury, adult or children, is a bad deal. In fact, when I AMA patients, like from a car wreck where I really think they should go to the hospital, every patient should go to the hospital, right? But they're like, no, I'm not going. I'm like, okay. Things to watch for, I'd give them concussion symptom warning signs of like, okay, if you have repetitive questioning, if you can't wake up, if you can't wake up, if they're drowsy and difficult to arouse, or most importantly, if they have vomiting or nausea, you need to go straight to the ER or call us back and we'll come get you. So just be aware. Those are good things to tell people when they AMA with head injuries. And that's going to happen. People are going to choose to not go to the hospital after a car wreck and stuff. And, there's not much you can do about that other than try to educate them and prepare them. So it's necessary for all children with possible head or spinal injuries after a traumatic event to be immobilized. Can be difficult because of the child's body proportions. We've talked about this. They have a really big what part of the head? Occiput, right? The back of the head. Children require padding underneath the torso or the shoulders to maintain that neutral position. I've drawn this for you with my terrible drawing before. So in order to put their neck up in a line, you have to pad underneath their shoulders usually and their torso. And it may be necessary to immobilize a child in a car seat. We'll show you how to do this in class. But generally, if a kid is in a car seat in a car wreck, you just remove and they're still secured in the car seat, like they didn't get ejected. You would just leave them in that car seat. Don't take them out. Okay, because that pretty well immobilizes them, and then you could further use rolled blankets or towels to further immobilize them. We'll show you how to do that in class. And so chest injuries, usually the result of blunt trauma. Okay, the chest wall, but keep in mind the chest wall in children is very flexible, and so two things: it's flexible. One, two, their muscles are not as developed as like mine. And so they can tire out more easy in respiratory distress. 1, 2, or 3 now. The thing to consider is I lost my thought. We're not redoing the video. All right, chest wall flexibility in children can produce a flail chest. What's a flail chest? That's where you break 2 or more ribs in 2 or more places, right? So you have a section of the chest that could be flail. What typically holds that chest into place in the pre-hospital environment? Remember, it's called intercostal splinting, so the muscles in between the ribs will hold it together, typically, okay? Very painful. And so what happens when the chest wall moves a piece of the chest wall moves in a section, like in the wrong direction, basically, so this will move out. It's called a floating segment, and that motion is called paradoxical motion, okay? And so the thing to watch with like a chest injury in adult or child is they're going to have a hard time taking a deep breath. And so in the long term, this is very likely to cause atelectasis, which is collapse of the alveoli, the grape-like clusters in our lungs. And 2, they're likely to get pneumonia. And 3, in the immediate term, they might be likely to be hypoxic because it hurts to breathe, so they'll take shallow breaths. They're also at a risk of pneumothorax, hemothorax. Okay, this is high yield review stuff with children that applies to adults as well. And so abdominal injuries, right? So the children can compensate for blood loss better than adults in the abdomen, but I've talked about this. They'll compensate until they don't, and then they just drop. Okay, you'll see that once, and you'll never forget it. When a kid goes into shock, like decompensated shock, it is like falling off of a roller coaster. It's just instant, and so they're on their way to death at that point. And so monitor all children for shock. If signs of shock are evident, prevent hypothermia with blankets, the same as in adults. Okay. And so they talk about blood loss. Okay. And so in a kid, they could lose up to 75% of their blood uh, before developing shock. And then I guess for a kid, they're at a higher, or for an adult, they're at a higher risk of blood loss. And so they could only, it looks like 60%. So I think this is kind of like a weird schematic, but signs of shock in children: tachycardia, which is fast heart rate, poor capillary refill. Remember with children, we check, well, in adults, we check capillary refill peripherally. So we might check it in the finger, here, and then we check it in the core as well. You're going to see different readings. It's probably going to be longer the further, more peripheral you go. Okay. And you would document each of those, by the way. So you'd say like, oh, in the hand or the fingertip, it's 4 seconds. On the bicep, it's 3 seconds. On the core, it's 2 seconds, or something like that. Okay. So you document each of those in your report. Now, burns are considered more severe in adults. Remember the pediatric rule of nines? They essentially add, normally an adult, the head is 9%, but in a kid, it's 18%. And because kids have really big heads. And so they steal that from the arms and the legs, and they shunt it up to the head. And so I'm not going to review the rule of nines. That's just a reminder. But they have more surface area to relative body mass, which means they have greater fluid and heat loss. And so burns in children are more critical in general. They have their own classification, which you'll have to learn in paramedic school, but you don't need to know that necessarily now. Just know, and it's intuitive, a burn in a kid is more severe, okay? And so they don't tolerate burns as well. They don't do as well. It's just a bad deal when anyone gets burned, especially a kid. And so they're more likely to go into shock, develop that hypothermia, and experience airway problems. And so remember, the shock is a form of distributive and hypovolemic shock, because you'll have this fluid shift, distributive, but also fluid will be lost through this burnt tissue right here. It'll weep out. And so you end up with this really nasty shock scenario, okay? Now, I would ask you, student, what is that? That's a kid's hand. What are these? Right? These are signs of abuse. Those are cigarette burns, okay? And so be aware of burns in children. It can be abuse. Now, typically you can see, and I've seen this, like kid will grab a pot of boiling water and pull it on them. I've seen that quite a bit working in the kids hospital, or like ramen noodles or coffee or something, like it'll burn them. Okay. And so that's a pretty predictable injury pattern. If a kid can walk and pull things off the counter, you're going to investigate it, but you're not going to necessarily think, oh, that's abuse. But a round burn like this to the hand or to like the butt cheek or to the face, right? That's obvious. This is very obviously a cigarette burn, right? That's not, that's not a hot piece of food, or, that's a burn. And so that's abuse. Okay, so watch for that. Okay, and we'll talk about abuse. I have a lot to say about abuse, but we'll talk about that. And then this one is what's called a dipping pattern. And so again, what happened was they dipped this kid into hot water. Okay, which is just heinously horrendous, egregious, just terrible. And so they dipped the kid in the hot water, and so you can see there's circumferential burns on the feet, and the ankles, and also in the hands. And so people that do this deserve cruel and unusual punishment, in my opinion, but we'll talk about that later. So this is another injury pattern. You can see that if they're forced submersion to a flex position, so that one was dipping them like this, but if you force them into not you, but if a piece of shit drops them into like a hot thing of water, their stomach, you can imagine like how their stomach kind of balls up like this, so you'll see this pattern as well. And so, anyways, this is just terrible. I hate talking about this stuff, but it was things we need to know. Okay, and so common ways that children are burned are exposure to hot substances. Where I've seen the majority of this is where like stove incidents, like cooking incidents, where kids. I've seen this several times, and it's very sad. They'll grab kids just grab stuff they don't know better, and so they'll just grab like hot water, like cooking on the stove, and it just pours on them. And so that creates obviously a very distinct burn to where it's going to burn from here down, and you'll see splashing from the water. Okay. Now you can also get burned from a caustic substance that's a little different, right? It's a chemical burn, but it's still treated similarly. It's a burn. Okay. And so infection is a common problem. And so kids' skin is generally thinner than adults, and so their immune systems are also not as robust as adults generally. When we're speaking about burn injuries, and so the infection is a problem you have to worry about. So these are when we would gather information, like, oh, they were burnt in a campfire, and then they jumped into the lake, right? Like something you really got to worry about infection, or they were burnt. I don't know. However you get burnt, you have to worry about the infectious sources that were involved. They're burnt, and they stopped, dropped, and rolled in dirt. things like that. Okay. And so we should try to be sterile. What's called a sterile technique when handling skin and burns. All burn blankets are sterile for that reason. Okay, so we'll show you a burn blanket in class. It's a blanket that's sterile. It's sterile. It's wrapped in like a. You'll see. And so consider child abuse in any burn situation. So you report any information about suspicions. So obviously, it's very criminal to burn someone, especially a child. And so this is where I'll just jump into the abuse section now. But when you suspect abuse, I've covered this before, but you can't let the abuser know that you suspect that, and that can be very hard to hide that emotion. I've actually had this happen, and so you have to convince these abusers that you're an idiot, right, and that you have no clue that they're being abused. And so you would have to be like, oh yeah, it's okay, yeah, oh, that bathwater is hot. Kid probably jumped into it where it's very clear that they were dipped into it or something like that. Oh yeah, it's fine. We'll get them to the hospital and take care of real quick and easy, right? Be real nonchalant, real cool, be real friendly. Even though you're burning on the inside. And so that's very important because if you arrive on scene and you're like, just flaming hot mad and want to go berserk and ballistic on this abuser of a child, they could, first off, you're going to turn the scene unsafe. Second, it's unprofessional. Third, it's not good care. Fourth, and most importantly, they could take the child away from you and run, right? Or they could tell you to get out of the house, or they could harm you, right? Because if you abuse a child, you're going to jail for a long time, hopefully forever. And so just be aware that it's really important to play dumb. Okay, very, very important. And so, don't be like getting on the radio as soon as you see it and saying, we need police, for an abuse, right? That's one of those to where maybe you're texting dispatch or you're walking out to the truck and you're going to a different channel that your partner's not on. I'm just saying you have to be careful that the abuser does not know that you suspect abuse until law enforcement arrives. Okay? Cannot stress that enough. Okay. Pediatric patients are managed in the same manner, and I've seen that tested, by the way, where they'll say, what should you do? Well, confront the parent, immediately notify law enforcement, notify the parent, notify law enforcement, or safely remove the child from the environment and begin transport. Right, that would be the most correct answer. And so, just keep that in mind. Okay, that is tested, and it is a very, 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 very real world application, and very hard to do to act like you don't know. And interestingly, I'll say that happened in the pediatric ER as well, right? So we had armed security at Cook Children's, but we would have to play dumb until law enforcement arrived, Fort Worth PD, or really even the jurisdiction it occurred in. So say this happened in North Richland Hills, we were waiting for a North Richland Hills cop to show up before confronting them, right? And so it was always a struggle to do this, especially with like sexual abuse and stuff like that. So yeah, pediatric patients are managed in the same manner as adults for burns, right? So prevent hypothermia. Shock is suspected. If patient shows bradycardia, you would ventilate. Remember, anytime, what do children die from? They die from hypoxia generally. Okay, monitor the patient during transport. Now, um, talking about bones. So remember, children have growth plates within their bones. It's at the end of the bone. So if I'm going to like very crudely draw a femur. Okay, that's a femur. The growth plate would be like somewhere here. Okay, and so that's called the epiphyseal plate. And so, if if a kid were to fracture their bone here through that plate, then they could potentially have growth issues after that. So growth of long bones occur from the ends at specialized growth plates. So remember, this is the end, right? These are potentially weak spots, okay, and you could have an incomplete or a green stick fracture. Okay, remember what a green stick fracture is? That's like if you were to go outside and take a green branch and break it, it splinters. It doesn't just snap. Okay, bones in children will do the same. Now, injuries to the extremities. Generally, extremities injuries in children are managed in the same manner as adults. So usually we'll use like splinting and stuff like that. But painful deformed limbs and evidence of broken bones should be splinted. So usually we just use splinting. Air splints are really good. Um, ice packs help. Children love ice packs. I make it rain ice packs. Okay, ice packs are really helpful for children. So we've talked about the Wong Baker pain, the faces, and I forgot to put it in here again. But they'll be like this. He's crying. And so they'll be like, point to which face you are. Okay. And so that's how we use the rolling Baker pain scale. And so interventions are limited to position, ice packs, and extremity evaluation or extremity elevation. Sorry. ALS intervention may be needed. So as paramedics, we can give them narcotics like morphine and fentanyl and Dilaudid and ketamine and nitrous oxide and all these cool drugs. And so even sometimes we can give these up the nose like in a like in atomized form. I've showed you that. And so that's really good. I used to do that a lot. We used to do that a lot at the kids' hospital. We would just squirt fentanyl up their nose, and it would work great. But also, don't underestimate the power of distraction for these injuries. You can distract them, and they just suddenly don't care that their arm's broken. It's really great. Distraction's a really powerful tool for children. But so, okay, we're going to talk about start triage later, and so we're kind of jumping out of order, but this is the way your book's written, so we're going to go with it. But there's the standardized triage system that I've kind of alluded to. We're going to talk about that later, but there's a variance of it called jump start. So a jump start is for younger patients, patients younger than 8 years and weighing less than 100 pounds. Okay, and so we use it a little differently. So we can just kind of zoom in here. And so, for jump start, if a green patient, or what they call a minor patient, is the walking wounded, right? So if they can walk, doesn't matter, they're green. So generally when you arrive on scene of an MCI, you say, if you can walk, come towards me, and everyone that can walk is now green, okay? And so that's generally how we do that. And we actually do that. And so remember, a black patient, not referring to their skin color, it's talking to their triage status. We could call these deceased. Remember, deceased means dead. And so apneic or no pulse after a head tilt, apneic or no pulse after 5 rescue breaths in a children. So that's the difference. So remember, kids die from hypoxia. So this would make sense that we would give them 5 rescue breaths to see if we could get something out of them. And if not, they're dead. Okay? So if they have respirations after a head tilt or 5 rescue breaths, they're immediate. They're a red. Okay? That's a critical patient. Okay? And then so if the respirations are less than 15 or over 45 a minute in a kid, then we would consider that a critical patient. So that's a red patient. Perfusion, if the radial pulse is absent, remember the radial pulse is over here on the thumb side. If that's absent, we would assume shock, and so that's a red patient. And then also if they're only responsive to pain, which is the P in the AVPU scale, or if they're unresponsive, that is also a red patient. Okay. All others, if they're alert, AVP appropriate, right? Alert, verbal, and pain appropriate, then then we would call them like a yellow. Okay. And so I just covered this. Obviously infants can't walk, so this is where you'd have to assess them. Okay. And so a yellow or delayed patient. Let me jump back. The idea of this is if you have 10 patients and 3 ambulances, who's taking the first ambulances? That's the idea of this. This is for a mass casualty incident where you have more patients than resources. And so you got to figure out who's going first. This is one of the systems you can use. And so a yellow, delayed treatment. So they may be catch the next round of ambulances, right? And so these are delayed patients. And so the presence of spontaneous breathing with peripheral pulses responsive to painful stimuli. So these patients are sick. They need to go to the hospital for sure. Before they're going to go before the people that can walk to the hospital, because even sometimes these green patients, we'll put them on a bus, like a school bus or an ambulance bus, or we'll load 6 of them up in an ambulance, because they don't need a lot of care. And so this actually just happened. So I'm just telling you, like, these are the patients that are not as serious, but these other ones are obvious. The red are the immediate patients. So the first ambulance is on scene, they're going to catch the red patients. Okay. And so apnea, responsive to positioning or rescue breathing, respiratory failure, breathing but without a pulse, or inappropriate painful response, right? These would be very sick patients, okay? Also, remember, it says if they don't have a radial pulse, that is also in this group. So remember, radial pulse. So if they don't have a radial pulse, they're in this group. Now, the black, these are deceased patients, okay? And so remember, with kids, you can do 5 rescue breaths and also a head tilt chin lift, and or a head tilt. And then so if that doesn't work, they're dead. And so that's actually one of the more difficult things you'll ever do as a paramedic is walk. I mean, this happened. I don't know why that I used to work in this county, at Erath County. We used to get like all sorts of like MCI car wrecks where you have like multiple patients and several of them are dead and stuff. And Amanda, actually, instructor Amanda Nevins, used to work with me out there. And so um, this would happen quite a bit to where you'd get there and you'd be like, oh, they're dead, they're dead. This one's alive, this one's trapped, this one's walking around crying. So like you would literally use this. And so, I can think of several times where you would just have to be like, you'd go over there, you'd look at them, they're obviously deceased, and like, all right, they're dead. And then you'd have to go on and help the ones you could, because you're the only ambulance for 5 patients. So you got to wait for more help to show up or more helicopters. And that's a very odd feeling, that to walk over someone and very quickly be like, you're dead, right? Moving to the next. And so this is where being highly trained and emotionally fit to do that is important. So I hate these tables, so I'm not going to go into this. It could be confusing. If you want to walk yourself through that, you can, but I don't want to confuse you. So also, I think it's annoying the colors don't line up with what they are. So anyways, so child abuse neglect. So any improper or excessive action that injures or otherwise harms a child could be considered abuse. And so this includes physical abuse. This would be like injuries, sexual abuse, particularly heinous, neglect, and emotional abuse as well. And so this is way too high of a number, but over 500,000 children are victims of child abuse annually. That's crazy. Many children suffer life-threatening injuries. Okay, and so this can be their own family. This could be mom's boyfriend. This could be by a caregiver. This could be at the church, right? There's the doctor's office. These possibilities are endless. Unfortunately, there's sick monsters everywhere. And so just be aware. This can happen anywhere, even in you're seeing injury patterns in the church and in clinics and doctors' offices, and that's just terrible. And so it's happening to school. And so child abuse occurs in every socioeconomic class. And so this is in the very rich, the very poor, in between, blacks, whites, Hispanics, Asians, right? It doesn't matter. It occurs in every class. And so be aware of the patient's surroundings, and you want to document your findings objectively. What does objective mean? It's things that you can see, things you can prove. And so you want to be careful with how you use your words, because in child abuse, there's going to be criminal charges, hopefully. And so this may go to court. And so your chart and your documentation, and you could get torn apart on the stand by defense attorneys in the prosecution. And so you want to be very careful with your words. These are the charts where you're having your partner read over it. You're double and triple checking your grammar, and you're making sure it's complete and accurate and exactly how you want it. And truthful, right? I'm not asking you to exaggerate on these, but be truthful and objective. And so ask questions of the following. So injuries typically for the age of the child. And so I'll give you an example. There was this kid that was probably like 6 months old. Maybe it's younger than that. It was a young kid. Maybe I don't remember how old the kid couldn't roll. The kid was too young to roll off the bed. And so the mom told us this kid rolled off the bed. And so the kid had rolled off the bed and broken its freaking pelvis. And so obviously it takes a lot of energy to break a kid's pelvis. And that doesn't happen from rolling off a bed. It especially doesn't happen in a kid that can't roll off the bed. So this is a case I can think of while working at a pediatric hospital where we had to play dumb until the cops got there and started interrogating her. And they found out it was mom's boyfriend that had done this. And so I guess the kid was crying consistently. And so just be aware, an injury pattern like a kid rolling off a bed that can't roll, that's too young to physically roll, doesn't make sense. Or an injury pattern of a kid getting into the pool that can't crawl or walk, right, and drowning, that doesn't make sense. Stuff like that. So does that make sense for a kid of this age to do that? It would make sense for a 5-6-year-old to walk out into traffic. That's tragic, but that's plausible. But you look for implausible stories, okay? MOI, the mechanism of injuries reported is consistent with injury. Again, it does not make sense for someone rolling off a bed to shatter their pelvis in a kid. That just doesn't happen. And so again, that doesn't make sense. And so the caregiving is behaving appropriately. Honestly, mom was stupid, and actually she totally believed that this kid or at least she was selling the story that the kid had rolled, that she was behaving appropriately. Interestingly, it was the mom's boyfriend who had abused this kid. And the reason I remember this kid is I was a tech in the ER, and I had to sit with this kid for I got to sit with this kid for 2 or 3 hours while they interrogated mom. And so I just remember this kid. It was very sad. And so evidence of drinking or drug use at the scene, obviously drugs and alcohol, not good. Delay in seeking care for the child. So, kid fell off the bed 3 days ago, and now we're coming to the ER because it won't stop crying. That is something that doesn't make sense. Oh, the kid's obviously has a deformed wrist from a skateboarding accident last week, and now we're coming to the ER. Those are the things that don't make sense, right? So delaying seeking care, and then a good relationship between the child and the caregiver or parent. And so there are multiple injuries at different stages of healing. This is probably the one you'll see the most common on exams. They'll say that there's bruises in multiple stages of healing. Now, bruises in multiple stages of healing can be a normal thing. If you saw me at 6, 7 years old, I mean, I was a little hellion, so there was bruises all over me, and I got spankings. But what I'm saying is, there's some patterns that would make sense, and then there's some patterns like this kid is just covered in head to toe of bruises. That could indicate abuse. Okay, so there is a you have to find a pattern in that. Any unusual marks or bruises that may be caused by cigarettes, heating grates, or branding injuries. So we brand cattle with like an initial. I mean, there's sick, there's terrible people that can do that to children. So that would be abuse, and they should go to jail forever. And so, are there several types of injuries, right? So again, oh, they have a broken wrist and a broken ankle and a head injury from falling off, from I don't know, from falling off the bed, right, or from getting in a fight with a brother, right? That doesn't make sense. So things like that. Oh, there's a very large handprint on the face, and they're saying, oh, his brother did that, right? It's the size of an adult hand. So these are all patterns you'd have to look for. Any burns on the hands or the feet that involve a glove distribution. So remember that pattern or that picture I showed you earlier? Um, this one. Whoops. I can't pull it up. Anyways, ah. So anyways, the one I showed you earlier where it shows like it burnt off his hands and his feet. Those are called glove pattern distributions. So watch for that in exam. They'll say there's a burn and a glove pattern distribution. Looks like the kid put on a glove, but it's really like burnt. Okay. Is there an unexplained decreased level of consciousness? Is a child clean, right? And so if the kid smells bad, has bad hygiene, kids can get dirty and nasty for sure, but, you know, oh, this kid's obviously hasn't bathed in several days type stuff. You'll see this. You really will see this. The kid just stinks. Their clothes are dirty, you know, very sad. Is there any rectal or vaginal bleeding? That should not happen, and so, there's kids that get STDs. So like, oh, they bring the kid in. The kid keeps scratching at their vagina, right? They keep scratching at their genitalia. Well, maybe it's an STD, from sexual abuse. Mom's boyfriend has chlamydia and gave it to the kid or something, so that happens. What does the home look like? So we get the unique opportunity that ER physicians and nurses don't get. We get to go in the home. And so you'll look in the home and be like, oh my God, there's cockroaches everywhere. There's no food in the pantry. There's no electricity. There's no heating. There's no cooling, right? There's dog feces all over the house, and these things happen. No one plans to call 911, so you get to see how people actually live. And so these are all things that you would look for and report objectively. Okay. Now, there's this mnemonic you can use. This gets tested every now and then. So it's called the child abuse mnemonic. So this is the mnemonic for assessing possible child abuse. So consistency of the injury with the child's developmental stage. So again, kids that can't walk or crawl should not be crawling into the bottom of a pool. That doesn't make sense. History inconsistent with injury. Okay, so the story could be changing or it just doesn't add up. Inappropriate parental concerns. So I've seen it both ways actually, where the parents are acting overly concerned, and then I've also seen it where they're very nonchalant. You'll see it both ways. So inappropriate either way, too much, too little concern. Lack of supervision. Delay in seeking care would be very odd. The affect, meaning their behavior is off, right? Bruises of varying ages, unusual injury patterns, suspicious circumstances, and the environmental clues, like the home life, okay? And so bruises, remember what's the medical word for a bruise? A hematoma. What color does it produce? Ecchymosis, okay? And so they could be in different colors. So remember, bruises are just blood underneath the skin. And so they could start off as like reddish or pink, right? That would be the color of blood. And as bilirubin breaks down, it's going to turn different colors. It could turn blue, then green, then yellowish brown, and then it'll fade. Okay, so if you ever wonder why a bruise turns yellowish brown, that's the same stuff that's in your urine, also known as bilirubin, and it's the same thing that causes jaundice. And so that's what's underneath the skin. So it takes a while to break down. So bruises to the back, buttocks, and face are suspicious and are usually inflicted by a person. The butt's very thick, right? It has fat and muscle, and so I'm not going to, spankings are one thing that's a hot topic right now. Spankings are not necessarily child abuse, but when you have bruises on the back and the butt and the face or something like that, you still could suspect abuse. Okay. And really, if they're getting spankings and as a form of punishment, um, to the point of bruising, that's not normal either, really. Children shouldn't bruise like that. It takes quite a bit to bruise a child. And so burns to the penis, testicles, vagina, or buttocks are usually inflicted by someone else. That would make sense. Burns that look like a glove. Remember, glove pattern. That is inflicted by someone else. Suspect child abuse if the child has cigarette burns or grid-like patterns. So you could also see this where they'll set them on like a hot grate, like a space heater, or on like a grill or a stove, or something like that, an oven, something like that. That's like that creates a grate, like a grate's like this, something like that, like a burn pattern like that. So fractures of the humerus or femur do not usually occur without major trauma. Falls from the bed are not usually associated with fractures. So again, when kids fall from a bed, unless it's a 10-foot tall bed, which just doesn't happen, they shouldn't be fracturing it. And so, could an adult fall out of a bed and fracture something like an 88-year-old lady with osteoporosis? Yeah, that does happen. But should a 8-month-old child be breaking bones? No. Could they be injured? Yes. Should they have fractures? No. That's not normal. And so maintain an index of suspension if the infant or young child sustains a femur fracture or a complete fracture of any bone. Okay, but especially a femur fracture, that takes a lot of energy to break a fracture or to break the femur in a child and an adult. Okay, now shaken baby syndrome, I've alluded to this, but remember, there's something called bridging vessels in between the layers of the meninges, and so a kid's brain is smaller than an adult's, and so what happens when someone shakes a baby, you can tear these. And so these veins can bleed, and that's called a or subarachnoid or subdural hematoma. Excuse me. And so that is called shaken baby syndrome. You can also tear the fibers within the brain because remember the brain is smaller than the skull in a baby, so there's a lot of jiggly room in there. And so this is the problem with shaken baby syndrome. So it's usually from a baby that won't stop crying, and so they get frustrated and shake the baby. And so this creates bulging of the fontanelles, subconjunctival hemorrhage. So you'll see bleeding in the eyes, right? Like the white of the eye. So just be aware of that. Damage to the cervical spine. Usually they're unconscious, but often they won't have evidence of external trauma, except what I'm telling you. They could have bulging of the fontanelles, the soft spot in the skull, and hemorrhage in the eyes. So those are things to look for in an unresponsive child. Neglect is failure to provide life necessities. So this would be water, clothing, shelter, personal hygiene, medicine, comfort, personal safety. If you suspect this, it needs to be reported. There are services to help with this. Doesn't necessarily mean the kid will be removed from the home, but it's, again, a mandatory reporting for children. So let me stop. Which probably has an upcoming slide, but you're obligated to report child abuse, child neglect, okay? What does that mean? It's called obligatory reporting. That means if you don't report it, you're at fault. Like you could be held criminally liable for that. Criminally, right? Like handcuffs, like going to jail, and civilly liable for that. And so you are absolutely required to report your suspicions and your findings to the authorities on this, okay? And so what is obligatory reporting meaning? That doesn't mean you show up to the ER and drop them and say, hey, home was really nasty, didn't have any water or food. Bye, right? That's not reporting. That means you initiate the report. And then you'll say, well, Hunter, isn't the hospital going to do a report too? That's fine, let them. But that's what the law says. You initiate the report if you've made the findings, okay? And so what? They get 5 reports on the same kid. Well, hopefully something will happen quicker. And so that's the law. You are absolutely required to report suspected child abuse and child neglect, okay? It is the law. Now, that's not the same for adults, okay? And so we've talked about that. But it's also true for the very old and those who are intellectually disabled. So let's say you have a 22-year-old adult with like severe intellectual disables, right? They're like physically, mentally retarded, whatever, okay? And you suspect abuse. You would be obligated to report that on their behalf because they are incapable of reporting it themselves. Same for the very old, right? Someone who has like Alzheimer's and you think like, oh, wow, like they have cigarette burns on them and there's all these injuries of abuse. You're obligated to report that, okay? Abused children may appear withdrawn, fearful, or hostile. Be concerned if the child does not want to discuss how an injury occurred, right? Parents may reveal a history of accidents, so be alert for conflicting stories or lack of concern. Abusers may be a parent, caregiver, relative, friend of the family. Generally, this is this is someone they know. Okay, and so that's the odd thing about like these types of crimes is it's generally someone that they know that is doing this. It's very rarely a random person, very rarely. Um, and so that's again what makes it even tragic. Usually a person that the family or someone trust. Again, like the church or a school, someone in the teacher or someone in the family or a family friend. You know, it's just terrible, terrible. So that's what I'm saying. EMTs in all states, this is called mandatory reporting, obligatory reporting, must report suspected abuse. Most states have special forms to do so. Supervisors are generally forbidden to interfere with the reporting. So, what are they saying by that? If you work in a terrible EMS system, they'll be like, oh, you have 20 minutes at the hospital, da da da, and then you got to be available. They couldn't do that if you're making a report of abuse, right? You have all the time in the world at that point. Okay, so that's something to be aware. Law enforcement and child protective services will determine whether there's abuse. So, what does that mean? You're better off to report your suspicions and let I believe in due process. I believe in the Constitution. I believe that you have the right to a fair trial and you have a right to due process and you're presumed innocent until proven guilty. I really do believe that, but that has to happen through an investigation. So you're more correct to initiate an investigation for someone who is truly innocent than to allow someone who's truly guilty to not be investigated and be found guilty. And so this is why it's mandatory to report this. You don't want any of these patients to fall through the cracks, right? So if you have a doubt of judgment, you should be reporting this. Okay, one, two. Like I said, the whole. I won't talk about that. But anyways, so yeah, I believe in due process, and they investigate these very thoroughly and very quickly, usually very quickly, a lot quicker than adults. But in children, they investigate this quickly. And so in Texas, the agency that handles these types of cases is the local police department will handle the criminal investigation, and then the Child Department of Protective Services, also known as in Texas CPS, Child Protective Services, and that's a department of the Texas Department of State Health Services. They will, and they're the ones that like put the kids in fostering, and they will do the home visits and the follow-up visits and stuff like that. They make recommendations to the courts. Very, very special people that do that job. That I mean, think about that. Your job is to handle abuse all day, and they get paid nothing, like 30, 40 grand a year. It's terrible. And so very stressful, and they work all hours of the night. It's just I mean, God bless those people. Anyways, sexual abuse. Children of any age and gender can be victims of sexual abuse. I used to know the number on this, but it is an alarmingly high. Uh, in fact, read this slide real quick. I need to look this up because I want to tell you. It's very high. I'm looking up something. Sorry, I should have looked this up beforehand. This is crazy, guys. This is from the government. 1 in 10 children are sexually abused before they turn 18. At least 40% of those victims were under the age of 12. Um, and so that is just, so think about that. You have a classroom of 20 students in first grade or, sixth grade or whatever. 2 of those children have been sexually abused. And so it's just a mind-boggling high statistic and terribly sad. And so just keep that in mind. It's a lot higher than what you would think. You're in a classroom of 20 students, 2 of them have been sexually abused, statistically. So anyways, assessment determined. So often longstanding abuse by relatives or close family members or something like that. Limited. So our assessment is limited, right? And so remember, there's specialized nurses that will handle these evidence collections. They call them sexual assault nurse examiners. Okay, so they're specialized in doing these exams and these histories. And in fact, at Cook Children's, we called it the same department. They had they had their own department within the emergency department that handled this. Again, experts in this field that are know how to deal with that trauma and talk to the child and gather evidence and collect and form an investigation. So do not examine genitalia unless there is evidence of bleeding or other injury. So someone got sexually abused, and there's usually, unless there's bleeding, there's not a reason to do a genitalia exam. Do not allow the child, the same with adults, allow the child to wash, urinate, or defecate until a physician completes examination. Ensure an EMT or police officer of the same gender remains with the child. Maintain professional composure. Assume a caring, concerned approach. Shield the child from onlookers. Just terrible. Makes me sad even talking about it. Obtain as much information as possible from the child and any witness. Okay. Generally, this isn't your job as much, but there may be a scenario where you're trying to assist with this. Transport all children who are victims of sexual assault, obviously. Generally, though, I will say these do need to go to a pediatric hospital if it's available, because that's where the experts in this type of trauma will be. Sexual abuse is obviously a particularly heinous crime. Cooperate with law enforcement officials in their investigations. Now, SIDS, this used to be called SIDS, but now it's called sudden unexplained infant death, or sudden infant death is what it used to be called. And so refers to sudden unexplained death when the cause is not known until the investigation is conducted. And so one of the causes of SIDS, one of the causes of sudden unexplained infant death is sudden infant death syndrome, also known as SIDS, which results in death that cannot be explained by any other means. And so these are really sad. I've had these too. Parents wake up, kid was fine the night before, they wake up, kid's been dead, they have rigor mortis, so they're stiff, and the kid's dead in the morning, and they don't really know why. And so there's speculation that there's a genetic component. There's speculation that children who co-sleep with parents. There's speculations that children sleep on their stomach. There's speculation of certain types of toys and things inside the crib. There's speculation of how this happens. There's speculation that epilepsy, which is seizures, is involved. There's a lot of speculation, but again, these are unexplained. Okay. So about 3,500 infants die from SIDS annually. Okay, very sad. I don't mean to joke about this, but we used to call it the blue baby hour. Around 7 o'clock in the ER at Cook Children's is when people would wake up and find their children dead, unfortunately. And so we would be bombarded with cardiac arrest in the morning with, SIDS children, unfortunately. And so baby should be placed on his or her back on a firm mattress in a crib free of bumpers, blankets, and toys. They believe that, if a kid's laying face down, or if there's a toy that could occlude their airway or something like that, or if the mattress is too soft where they sink into it, these could all lead to their hypoxia and death. Baby should sleep in the same bed, chair, or sofa as an adult. I've had this happen as well, where mom woke up and she was laying on top of the infant. Very scary. And the kid was dead. So she suffocated the kid by sleeping on top of it. And so these are all things. Breastfeeding, the use of a pacifier may lower the risk. They don't know why this is. They believe the reason for this, though, is that the baby can breathe through their nose a little bit easier than, so they might have an alternate way to breathe if their mouth becomes clogged, and vice versa. That's the hypothesis on it, but I don't think it's well understood. So SIDS, this happens in moms that are young, mothers who smoke during pregnancy, mothers who's used alcohol or illicit drugs during pregnancy or after birth, and a low birth rate. And it can occur any time of the day. So again, I jokingly say about blue baby hour, 7 o'clock in the morning, but this can happen, during the daytime nap or whatever. Okay. And so you're faced with 3 tasks: assessment of the scene for a SIDS baby, assessment and management of the patient, and communication support of the family. And so, victims of SIDS will be pale and blue, not breathing, and unresponsive. A lot of times when I've seen this, I've seen it to where they're rigored and they're just very, very, very clearly deceased. And so at that point, there's nothing you can do. And so other causes include, sepsis, like an overwhelming infection, child abuse, airway obstruction. It's probably pretty common. Epilepsy, meningitis. These are all possible causes. And so, hypoglycemia, congenital metabolic defects. Those are possible. Accidental poisonings, and so, you do the XABCs as always. And so depending on how much time has passed, the child may have postmortem changes. Remember those postmortem changes, we call it rigor mortis. This is when there's chemical decomposition of the muscle and they become stiff. Where's the first place we see rigor mortis? In the jaw. So if I go up, if I get called to a cardiac arrest, the first thing I do is I go up and I shake their hand. I shake their jaw. And if their jaw is stiff, they have rigor mortis. I'm not going to work them. But if their jaw is loosey-goosey, I'll probably work them. So you'll see rigor mortis set into the jaw first. Not my opinion, by the way. The research backs that. And so if you see these signs, you would call medical control. And again, it's better to initiate CPR and call medical control and say, hey, we've noticed rigor mortis. And also, what's the other one? Dependent lividity. This is where blood will pool with gravity. So if the kid's laying on their stomach, per se, you're going to see their face and their stomach and their interior portion of their body is going to be bruised. It looks like a bruise. It's really just blood that has pooled. If there's no sign of postmortem changes, you would begin CPR immediately. And really with kids, you'll see too, we tend to give them the benefit of the doubt, even though that's controversial. But, if there's an adult where it's questionable, they're probably pretty dead and they're like 65 years old, you're less likely to have someone try to attempt resuscitation. But if there's like a kid where like, "Ugh, we really don't know how long they've been dead, maybe their jaw's a little stiff, maybe, there's a little rigor. I mean, I don't know. You're more likely to work them is what I'm saying. Whoops. Uh, Pay special attention to any marks or bruises on the child before performing any procedures. I will tell you, typically these people meet you at the curb, right, or at the door holding the kid. Carefully inspect the environment, noting condition of the scene and where the infant was found. Assessment should concentrate on the signs of illness, the general signs of the house, signs of poor hygiene, right? Family interaction. Where was the infant discovered? Were they found on the sofa? Were they found in the bottom of the bathtub? Things like that. Whoops. And so, an infant, really any death of an infant is incredibly devastating. So, it tends to evoke a very strong emotional response among healthcare providers. I've seen people go cuckoo working pediatric arrests and stuff, like providers. And so, just be aware of that. Everyone handles grief differently. Cuckoo is probably not a nice word to use, but I've seen people behave oddly and out of character. And so, again, it's different. I don't have children. And so it's different if you have children, there's more of a connection. And so, you know, and everyone to each their own. And so allow the family and the healthcare providers to express their grief, as long as it's non-interruptive way, right? Interrupting like resuscitation or safety. And so provide the family with empathy. What's empathy? That's the ability to walk in someone else's shoes, right? To feel someone else's emotion and understanding. The family may want to initiate resuscitation efforts, which may or may not be conflict with your EMS protocols. Introduce yourself to the child's parents or caregivers and ask about the child's date of birth and medical history. Only when appropriate. I wouldn't do that immediately if you've determined that they're too dead to work. And so do not speculate on the cause of the child's death. This is very important. This is why we have medical examiners that will figure that out. You don't want to speak out of turn and be like, oh, this is SIDS, and it's not. It's like that's a complex diagnosis. And so let someone else make that. The family should be asked whether they want to hold the child and say goodbye. I've seen this a lot in the pediatric ER. We would let them hold the child, and there was like we had like these, it's sad, we had boxes where they would like remove some of the child's hair, and they would also do footprints and palm prints on like a paper of the child. And they had like these nice, as nice as it can be, these nice boxes the parents would have when leaving the ER, so they wouldn't leave there completely empty-handed without their child. And so, yeah, sometimes they want to hold the child, and I've seen that happen for very long periods of time, for hours, and we would give them the room. We would just let them sit in there, and just let them grieve. What they do. And so the following interventions are helpful. Use the child's name. Speak to the family member at eye level, and I've seen this tested. Use the word dead and died instead of using like words like they passed away, they're gone, they're no longer with us, right? And so, I would just have to say, I'm sorry, terribly, terribly sorry, but your child is dead. They are deceased, right? And so those are like very clear words. You don't want to use word like, again, passed away, they've gone to heaven. You could start with they're dead. I'm sorry, they've gone to heaven. I've done that. But you need to use the word dead or died. It's better. It's more clear. It's not, what? Wait, are they with us or not? Are they dead or not? So I'm sorry. So acknowledge the family's pain, but never say, this is important. I've seen this tested as well. Never say, I know how you feel. You don't. Even if you've had a child die, which would be rare, but even if you've had a child die, you don't know exactly how they feel. Okay, so we don't use it. When you say that, it invalidates their emotion. So we don't say that. So you don't say that. Offer to call other family members or clergy. I've done that. Who can I call to come be with you, to come help you? Notice, keep any instructions short, simple, and basic. Even with adults, what I would typically say, it's like, I'm very sorry. Who can I call to come help you? We're going to be here with you until the next steps. And when you're ready, I'll tell you what the next steps are, right? And so it may take a while, and then I tell them, like, okay, well, anytime there's a death outside of the hospital, the sheriff's department or the police department will come, and they will come help with the investigation and notifying the medical examiner or funeral home. This is very normal. It does not mean that they suspect anything, but this is the normal process when we have someone who unfortunately dies outside of the hospital. And so you just tell them stuff like that, just to inform them, because it can be very alarming when their husband or wife had died and like the police show up. They're like, why would they be here? But it's standard protocol. And so wrap the child in a blanket and stay with the family while they hold the child. Do not remove any equipment that was used in the resuscitation. Again, I've seen this tested as well. there's a lot of questions around death that get tested. And so this is very controversial, but it is the rules. If someone is intubated, like they have a tube down their throat or they have IVs and stuff, you do not remove it. Okay. And so this is why it's better just to wrap them up in a blanket with all that stuff in there. Everyone expresses grief in a different way. Some will require intervention. Many caregivers feel directly responsible for the death of the child. Some EMS systems will arrange for home visits after a child's death for closure. And so you would need training for these visits. We don't do this, but uh, that's something that the hospital district has actually invested a lot of time and money in. Is we have like a mental health department and like resiliency people and stuff like that. And we have like brochures and flyers and grant money to help with like the community with grieving and stuff like that. That was after my time on the ambulance, but I know it exists and I think it's a great program. And so the death of a child can be very stressful. The ones that again, I don't have children, but I know this would be very different if I had children. And so just be aware, everyone handles this differently. Uh, Take time before going back to the job. I mean, I can't think of how many kids I've seen dead. I don't know, 3 to 5 probably outside of the hospital, maybe five, maybe five, probably five or so. But in the hospital, a lot more than that, a lot more than that. But anyways, these are they're bad. They're very sad. Okay, and so be alert for signs of post-traumatic stress in yourself and others. Consider the need for help as signs occur. Now we're almost done, but we need to talk about something called an ALTI. Okay, that's an apparent life-threatening event, and so these are actually very common and scary. And so this is for an infant who are breathing, cyanotic, and unresponsive, and sometimes they'll resume color and breathing with stimulation. And so these are like the mom that's putting the kid to bed, and then they notice that the kid's not breathing and they're cyanotic. And so you get called for pediatric cardiac arrest. The cavalry comes as fast as they can, and you get there and the kid's like pink and crying. And so that's called an ALTI, an apparent life-threatening event. Okay, and so they're uh, they're at a higher risk of cardiac arrest after this. So a lot of times they get admitted for like a day or two for observation, but they need to go to the hospital. Okay, and so when you have a kid that like stop breathing for a while and then with stimulation they start breathing again, that's called an ALTI. So I can't tell you how many times you've been called out. I've been called out to a pediatric cardiac arrest. You're just going as fast as you can to get there. Everyone's coming, lights, sirens, and then en route the kid's awake and crying. That's probably not a cardiac arrest. That's an ALTI. And well, I'll ask you, what could be confused as an ALTI? Hypoglycemia, one, two, epilepsy. Remember, kids don't always have full body tonic-clonic seizures. They'll just have slight dysregulation, especially of the nervous system. And so this is where they may not be breathing effectively, so they in fact do turn cyanotic. And so, epilepsy could be confused as an ALTI. Okay, and so just be aware. And remember, ALTI is an apparent life-threatening event. After an ALTI, the child may appear healthy with no signs of illness or distress. I'm telling you, it's the one where you like go into a cardiac arrest of a kid, and then you get there and the kid's pink and crying. And so remember, crying babies are healthy babies. So, but it doesn't mean it can't happen again, and it does mean they need to go to the hospital. And so you would want the caregiver to ride in the back of the ambulance. You want to gather as many details as possible. When did they eat? Have they been sick? Did they start any medicines? Did they stop any medicines? Have they had fevers? Anyone else in the house sick? Stuff like that. So you want to try to gather history to figure out what could have caused this. Um, So a brief unresolved or unexplained event. So I don't brief changes in skin color as pale skin or cyanosis, choking, absent slow or regular breathing, decreased level of consciousness, right? But again, when you assess them, there's no abnormality found on assessment. And so again, you need to transport these patients. All right, questions. I hope we get these right. I work in a kids hospital. I should have these down. How does pediatric anatomy differ from adult anatomy? The trachea is more rigid. No, it's actually softer. The tongue is proportionally smaller. No, it's actually larger. The epiglottis is less. No, it's way more floppy. And so the head is more proportionally larger. Yes, correct. It's much larger. What portion of the head is larger? The occiput. Oh, now you say that. Good. When a small child falls from a significant height, the blank most often strikes the ground first. The head. Their heads are huge and they're really heavy. So, like, imagine me strapping like a 30-pound weight to the top of your head and you fall. What are you going to hit first? Your head, right? Your muscles, your coordination, your top heavy. So, the head. Booyah. When assessing a conscious and alert 9-year-old child, you should. So this is school aged child. Isolate the child from his or her parents. No. They're going to be more comfortable with their parents. Allow the child to answer your questions. Yes. They're old enough to communicate with you, so you could talk directly to them. Obtain all information from the parent. No. That would be for like preschool and younger. Avoid placing yourself below the child's eye level. No, you want to be right at the child's eye level. Be careful that with children, you're all automatically taller than them, and if you're not, sorry. But you should don't look down on them. That can be intimidating. So you want to be at eye level. That's any patient. You should be at eye level. The purpose of a shunt. I don't even remember talking about this in this lecture, but I'll tell you. This is called an AP or AAV shunt. And so what this is it it's this one. It minimizes pressure within the skull. Maybe I did talk about this, where you'll have a buildup of cerebral spinal fluid. So they'll put like a straw, a tube that'll lead through that area and it'll drain into the peritoneum. And so this is a close one. This is wrong. It drains excess fluid to the peritoneum, which is the abdomen. Okay? A VP shunt. Ventriculoperitoneal shunt. And sometimes you can get clogged. And if they get clogged, um, it creates, the fluid's going to build up and it can't drain because that tube's clogged. And so they'll have like ICP problems, headache, blurred vision, nausea, vomiting, stuff like that. Which of the following statements regarding febrile seizures is correct? So I'll just quickly recapitulate. What is a febrile seizure? A seizure in someone from 6 months to 6 years of age that is related to fever. Generally, they don't have a postictal state or a very severe postictal state. It can last up to 15 minutes per the book, which I think is astronomically long, but that's what the rules say. What's the treatment? Generally, you want to cool the patient, but not so much that they shiver. So let me read these real quick. That's possible, but I don't think that's what it is. No, it's 6 months to 6 years is the requirement. On B, C, no, they should last less than 15 minutes. Oh, okay, yeah, it's D. D. Febrile seizures usually last less than 15 minutes and often do not have a postictal phase. What's the postictal phase? This is where someone is very tired, lethargic, short of breath, uh, and generally unresponsive or slow to respond. Altered mental status after a seizure. D. Yeah. You respond to a sick child late at night. The child appears very ill, has a high fever, and is drooling. He is sitting in a tripod position, struggling to breathe. You should suspect. Oh, okay. The key word here, guys, is drooling. Drooling. What does drooling mean? It means they can't swallow their spit because that little flappy thing in the back of their throat hurts. This is definitely epiglottitis. It is a bacterial infection that is preventable with an immunization. Vaccinate your children. And this will cause drooling, what they describe, drooling, tripod position, high fever, and it can lead to airway obstruction so severe that they could be apneic. It's a life-threatening emergency. But the key word here is drooling. My conscious child who swallowed an unknown quantity of pills. No, I don't think so because they don't tell you what the pills are or when it was ingested. Remember, activated charcoal, you can't give it to certain petroleum-related products, and I think it doesn't work for aspirin. It also doesn't work for ethanol. It needs to be given within 1 hour of ingestion as well. B sounds like a pretty good answer. No, let's see. No, we never induce vomiting, ever, ever. Believe it or not, that used to be a treatment. It's not anymore. But I'm going to say B. This is an interesting one. This is interesting. This one down here. What made this wrong was elevating the legs. So yeah, if someone's vomiting, you can put them in the recovery position on their left side, but elevating the legs is weird. I don't know why you would do that. When using the mnemonic child abuse, gosh, to assess a child for signs of abuse, you should recall that the D stands for. No, no. Um, I remember delay in seeking care was in that mnemonic, and I really thought hygiene was in there too. But I think that this one is going to be the actual H in child, and this one's the D. I'm going to go with this one, I think. I think it's delay in seeking care. Good. Okay, hygiene's not in there. Okay, that's history of inconsistent injury, inconsistent with injury. Hygiene may be more like environmental. Gee, this one's long. 4-year-old girl fell from a second-story balcony and landed on her head. She is unresponsive, has slow irregular breathing, has a large hematoma, a bruise to the top of her head, and the bleeding and is bleeding from her nose. You should. Okay, this one's wrong because of the nasopharyngeal airway. We don't do that in head trauma, so that's why that one's wrong. This one is wrong. This one's okay, but this one's a lot better of an option. This one is wrong because the full body scan you would not do before addressing life threats. So I'm gonna go C. Yeah, yeah, good. Again, you can pause these if you want to see them, if you're even watching this. All right, the AFPU scale is used to determine a patient level of consciousness. What does the P stand? It's pain. Pain. Alert, verbal, pain, and unresponsive. Right? And so if someone's alert, hey, what's up? They answer. If they're verbal, or if they're alert, I'm sorry, it's just you walk in the room, they talk. Verbal, sir, wake up, sir. It's just loud stimulus, sir. Pain would be like a sternum rub or some type of painful maneuver to try to elicit a response. Sternum rub is my go-to. And then unresponsive is just fully unresponsive. So C, final answer, hundo. All right, that's all I have for this video. I appreciate y'all's attention.